Welcome back to the deep dive. Today we are undertaking one of the most critical and, frankly, intense deep dives we've ever done.
I think so.
We are looking squarely at the world of acute crisis management, focusing on, really, three massive clinical themes: infectious diseases, emergency trauma care, and disaster preparedness.
Right.
This material is a comprehensive review for any nurse who has to operate when minutes or even seconds truly matter.
That's absolutely right. We're synthesizing the core of a major unit from medical surgical nursing texts,
Mm-hmm.
the one that covers acute community-based challenges.
Yeah.
Our mission, really, is to extract the essential knowledge, skills, and attitudes. The KSAs.
Those are KSAs.
Yeah, the things that allow a professional to switch instantly from routine care to high-stakes crisis mode. We need to go beyond just definitions and really understand the application of these skills.
In places ranging from a busy emergency department to a global pandemic zone,
Exactly.
the text frames this entire unit with a scenario that feels, very real to anyone living through the last few years.
Oh, absolutely.
A home health nurse finds herself at the epicenter of an outbreak of a novel respiratory virus. Standard protocols are useless, evidence is changing daily, and she has to figure out how to keep her community patients safe.
And that scenario immediately forces us to lean on the foundations of evidence-based practice, or EBP,
Right.
which is a key pillar of the quality and safety education for nurses, or QSEN competencies. EBP is defined as the integration of the best current evidence with your clinical expertise and, crucially, the patient's values and preferences.
Okay, let's unpack this for the nurse in that exact chaotic moment. When the protocols are changing by the hour during a novel virus crisis, how does that EBP framework actually create action? What KSAs do you need to operate safely?
Well, the required knowledge shifts instantly. It's not enough to know what EBP is. You have to know the role of evidence in determining best practice,
Where to find it?
and which federal, state, and local sources, like the CDC or WHO, you must rely on to identify that rapidly evolving evidence base. Moreover, you need to understand that the evidence dictates how you educate the public. It determines effective infection control for, every age group and every comorbidity.
So finding the evidence is the first hurdle. But the skills piece seems even harder because you're finding it under duress.
Exactly. The required skills are being able to rapidly read original research, locate evolving evidence reports and clinical guidelines, and quickly differentiate between credible sources and, well, misinformation.
It's like a triage of information itself.
That's a great way to put it. You need the skill to determine right then which infection control techniques are actually effective, which is a major challenge when the science itself is fluid.
And here's where the attitude, the disposition comes in. I think this is where the most stress happens in a crisis.
It is. The essential attitude is accepting your limitations. You have to acknowledge the limitations in your own knowledge and expertise before you decide to deviate from what evidence-based best practices were yesterday.
And that EBP attitude requires you to reflect on how these new restrictions, isolation, masking, visiting bans, are really impacting people's lives.
Yes, empathy isn't just a soft skill here. It's essential for ensuring compliance, which is, at the end of the day, an evidence-based outcome.
That sets the stage perfectly for Chapter 66. Before we can manage the crisis, we have to master the language. Let's start with foundational terminology that is so often mixed up: colonization, infection, and disease.
This clarity is absolutely fundamental. So colonization is the simplest state. Pathogenic microbes are growing in the body, but they are not interacting with the host.
Meaning no symptoms.
No symptoms at all. The host is completely asymptomatic. A classic example is carrying MRSA in your nose without ever getting sick. You are colonized.
So colonization is just presence without harm.
Correct. Infection signifies that the microbe is growing in the body, it's proliferating, and it may or may not be communicable to others. The host might still be asymptomatic, or they might show some early, non-specific symptoms.
And then disease.
Disease is the state where the infection causes clinical evidence, where signs and symptoms are apparent and the host is actively interacting with the organism.
Okay, next, let's tackle the triad that dominated headlines for years: outbreak, epidemic, and pandemic.
Right. An outbreak is a simple, localized occurrence of a disease that exceeds the usual expected levels within a population.
So a spike in a neighborhood.
A spike in a neighborhood. An epidemic is a widespread outbreak from a single source within a community or population that significantly exceeds that anticipated impact. Think of a regional flu season that hits much, much harder than predicted.
And the escalation to pandemic, what's the key element there?
A pandemic is an epidemic that is spread across multiple countries or continents. But the crucial element, especially with novel pathogens like SARS-CoV-2, is that populations universally lack prior immunity.
Ah.
That lack of immunity is what inherently drives the severe strain on economic, social, and healthcare resources globally.
We also need to understand the elements that enable the spread itself: reservoir, latency, and carrier.
The reservoir is just where the organism lives and multiplies. It could be a person, an animal, or a substance like contaminated water.
Simple enough.
Latency describes the interval after the primary infection when the microorganism is inside the roost, but isn't producing any clinical evidence of disease. It's essentially hidden, which makes tracking really complicated.
And a carrier.
A carrier is an asymptomatic individual who's capable of transmitting the pathogen to others. They are infected but show no signs of illness at all.
All these elements come together in the classic chain of infection. For nurses, this chain isn't just academic, it's the blueprint for where to intervene, right? What are the 6 links?
Every single link is a point of vulnerability we have to exploit. We start with the causative organism itself. Is it a virus, bacteria, fungus?
Oh.
Second, the reservoir. Where does it live? Third, the portal of exit. How does it leave the host, say, through sneezing?
Right.
Fourth, the crucial route of transmission.
Contact, droplet, airborne.
The actual vector, yep. Fifth, the portal of entry into the new host, like mucous membranes. And finally, the susceptible host, someone lacking immunity.
And infection control is just about breaking one of those links.
That's all it is. Wearing an N95 to block the portal of entry for an airborne agent, for example, you break the chain.
This systematic thinking is so vital, especially when dealing with emerging infectious diseases. How does the text define this category?
These are human infectious diseases that have seen an increased incidence within the last 2 decades, or those that have the potential to increase in the near future. It's a big umbrella term.
It covers everything from known agents resurging, like pertussis, to completely novel pathogens.
And even agents used in bioterrorism.
The source material gives us a really startling summary of how varied these threats are, looking at incubation periods and transmission modes.
It really shows why a one-size-fits-all approach to public health just fails.
Yeah.
I mean, look at the extremes. If you contrast HIV, which is spread sexually or perinatally,
Right.
with a median latency of 10 years without therapy,
10 years.
with something like rotavirus, gastroenteritis, spread fecal-oral with an incubation of 24 to 72 hours, your contact tracing strategy has to be fundamentally different.
Right. For rotavirus, it's immediate and short. For HIV, the window is prolonged, often before a diagnosis is even made.
Exactly. And then you have Ebola virus disease with an incubation of 2 to 21 days, spread only by direct contact with blood or body fluids, a critical distinction, as it is not airborne.
Or Lyme disease from a tick bite.
Or SARS-CoV-2, the cause of COVID-19, with its principal modes of droplet and contact, and that variable incubation of 2 to 14 days, which is precisely why it was so difficult to contain initially.
Shifting our focus now to the healthcare environment, let's talk about healthcare-associated infections, or HAIs. These are a massive patient safety and, well, financial challenge.
A huge financial challenge. HAIs are infections that were not present or incubating at the time a patient was admitted. They are essentially a sign of system failure.
And there's a national tracking system for this.
There is the CDC's National Healthcare Safety Network, the NHSN. And why tracking matters so much is because the Centers for Medicare and Medicaid Services, CMS, uses this data to impose financial penalties on facilities with high HAI rates.
So preventing HAIs is directly tied to a hospital's solvency and its public reputation.
Absolutely.
The core strategy for prevention is isolation precautions, which are categorized into 2 tiers. What are those 2 foundational tiers?
Tier 1 is standard precautions, which we apply to every single patient. Tier 2 is transmission-based precautions, which we layer on top of standard precautions when a specific contagious organism is suspected or confirmed.
Okay, let's nail standard precautions first. What's the foundational assumption?
The universal assumption is that all patients may be colonized or infected with microorganisms, regardless of whether they're symptomatic. Therefore, a uniform, aggressive level of caution is required for every patient interaction.
And the elements include things like hand hygiene, PPE, correct handling of equipment.
Sharps, injury prevention, environmental control, all of it.
Hand hygiene is always called the single most important intervention. Let's delve into the distinction between alcohol rubs and soap and water.
It is the most frequent cause of bacterial transmission, the hands of healthcare workers. So, alcohol-based products are preferred because they're generally more effective and easier to use.
As long as your hands aren't visibly soiled.
Right. But, and this is the critical distinction, soap and water must be used when hands are visibly dirty or after contact with patients who have spore-forming bacteria, most notably C. difficile.
Because the alcohol rubs don't kill the spores.
They don't kill the spores. You need the mechanical scrubbing with soap and water to remove them.
That's a key insight. Let's also touch on PPE selection, particularly gloves.
The source material indicates a preference for latex or nitrile gloves over vinyl.
Why is that?
They offer better resistance to puncture and a better fit. But this has to be balanced with monitoring staff for potential latex hypersensitivity reactions, which can be life-threatening.
Now, tier 2, transmission-based precautions. Let's start with airborne precautions. What makes this category so demanding?
Airborne spread involves organisms transmitted by small droplet nuclei that are suspended in the air over a distance, like TB, measles, or varicella.
Chickenpox.
Right. And this requires specialized engineering controls. The patient must be in a private room with negative air pressure.
Where the air is getting sucked out of the room.
Exactly. It's rapidly exchanged and exhausted directly outside with 6 to 12 air changes per hour.
And the nurse's personal protection.
It's mandatory use of a NIOH-approved N95 filtering face PEETS respirator. This is not a surgical mask. It requires the nurse to have been fit tested and to perform a user seal check every single time it's put on.
Making sure no air leaks in around the edges.
Correct. And you can do a quick check of the room's negative pressure by observing a tissue held at the door gap being pulled into the room.
Okay, next, droplet precautions, which are often confused with airborne.
The difference is the particle size. Droplets are large particles generated by talking, coughing, or sneezing. They don't stay suspended in the air. They travel a short distance, usually 3 to 6 feet, and then they fall.
So things like influenza, mumps, rubella.
Exactly. The nurse wears a face mask when within that 3 to 6 foot radius of the patient. Because the risk is based on proximity, the door can remain open.
And finally, contact precautions.
Contact is for organisms spread by direct skin-to-skin contact or indirect contact via contaminated equipment or surfaces. Think MRSA, VRE, or C. diff.
So the patient's in a private room.
Private room or cohorted. Barrier use is critical. Gowns and gloves are mandatory upon entry, and hand hygiene is paramount upon leaving the room.
The process of removing this gear doffing is the most dangerous part, isn't it? That's when self-contamination happens.
Is the most dangerous part.
Let's walk through the exact steps for both donning and doffing. This is a life-saving skill.
Okay, so the sequence is designed to prevent contaminated parts from touching clean parts. Dotting, or putting on, starts after hand hygiene. First, the isolation gown.
Gown first.
Second, the N95 respirator with a fit check. Third, the eye protection, like goggles or a face shield. And last, the gloves, making sure the gloves pull up and cover the cuff of the gown.
Now, doffing, the removal. The sequence is reversed and has to be managed so carefully to contain contamination.
The critical moment is removing the most contaminated pieces first. So first, you remove the gloves.
Gloves off.
Second, you remove the gown. You untie it, pull it away from your neck and shoulders, touching only the inside, and roll the contaminated outside inward before you throw it away.
And what happens right after the gloves and gown come off?
Immediate hand hygiene. You have just handled the most contaminated external surfaces.
Ah, okay. That's a key step.
It is. Then third, remove the eye protection, handling only the scrap, not the contaminated front. Fourth, remove the respirator or mask, again touching only the straps or ear loops. And finally, a closing round of hand hygiene. That meticulous attention ensures you don't inoculate yourself.
Let's briefly highlight the specific HAI organisms mentioned. We already discussed why C. difficile is unique because of the spores.
Yes, the spore-forming capability allows it to resist many disinfectants and those alcohol rubs. It can cause severe pseudomembranous colitis and lead to sepsis.
And VRE.
VRE, or vancomycin-resistant enterococcus, is the second most frequent HAI source. It's incredibly hardy in the environment, which makes it easily transmissible, and it can cause severe infection in wounds and the blood.
And MRSA is just the strain of Staph aureus that resists specific antibiotics.
Right, and it circulates in both healthcare and community settings.
The COVID-19 pandemic caused, well, a tectonic shift in how we approach infection prevention. The source material mentions the idea of universal pandemic precautions, possibly succeeding standard precautions. What does that imply for the future of nursing?
It implies a permanent elevation of assumed risk. The experience of constantly changing protocols, Resource scarcity and mass illness led clinicians to recognize that standard precautions, as they existed, might be insufficient in the face of future novel pathogens.
So it might mean something like widespread mask usage or enhanced air filtration becoming the new normal, even when an outbreak isn't active.
Exactly. It's about raising the baseline level of protection.
Let's focus on the deep dive into COVID-19 management from the text. The list of risk factors for severe illness is extensive, and nurses have to know it by heart.
The risk list is a who's who of chronic conditions. Primary risk factors included advanced age, 65 and over, and residents in long-term care facilities.
And specific comorbidities.
Cancer, chronic kidney disease, COPD, heart failure, immunocompromised states, obesity with a BMI of 30 or more, pregnancy, and type 2 diabetes. A nurse has to use this list to prioritize protection and resource allocation.
What about the clinical presentation?
It was a very wide spectrum. About 80% of people had mild to moderate symptoms they could manage at home. Fever, cough, extreme fatigue, muscle aches, and of course the classic signs of loss of smell, anosmia, and taste, ageusia.
And the rest required hospitalization.
For severe respiratory distress, yes.
In terms of diagnosis, the nurse's role extended to managing risk during the testing itself.
Correct. Diagnosis was primarily via nasopharyngeal samples analyzed with molecular or antigen tests. To minimize the exposure risk for healthcare workers, a key intervention was advocating for and observing patient self-administration of nasal swabbing whenever that was feasible.
Let's look at the rapid vaccine development, Operation Warp Speed.
It was an unprecedented effort. The rapid emergency authorization of mRNA vaccines like Pfizer and Moderna, less than a year after the virus was sequenced, was historic.
And they required 2 doses.
2 doses for full efficacy. And nurses needed to be aware of the extremely rare risk of anaphylaxis, higher than for other standard vaccines, and be prepared with epinephrine and immediate support if it occurred. A major nursing imperative was advocacy.
Urging nurses to get the vaccine themselves to protect everyone.
Exactly. To protect themselves and their patients.
And what about mitigation strategies? We all know the basics, but what's the tangible evidence supporting these interventions, like masking?
This is a perfect example of a tangible EBP nugget. So nurses promoted 3 essential practices: social distancing of 6 feet, frequent hand hygiene, and masking.
Right.
The evidence supporting masking included a really compelling anecdote, a study involving 2 hairstylists in a community where masks were mandated.
I think I remember this one.
Both tested positive for the virus, yet they served 139 clients, all while wearing multi-layer masks.
And the result?
0 symptomatic secondary cases among the clients. It's a perfect illustration that 2 layers of breathable fabric worn consistently are a powerful barrier to transmission.
That is a phenomenal piece of insight that makes the practice stick. Moving on to other emerging diseases, let's look at 2 vector-borne illnesses, Zika and West Nile.
Zika virus, transmitted primarily by Aedes mosquitoes and also sexually, gained prominence during the 2015 Brazil outbreak.
The most critical risk factor for a nurse to assess is travel or sexual contact, especially in pregnant women.
Absolutely, because of the link between maternal infection and congenital microcephaly in the fetus.
And West Nile virus.
West Nile uses birds as a reservoir and is also transmitted by mosquitoes. The vast majority of people get West Nile fever, which is mild. However, less than 1% develop severe neuroinvasive illness, meningitis, encephalitis, or paralysis, with a 10% mortality rate in those severe cases.
And since there's no specific treatment, nursing care is strictly supportive.
Strictly supportive, managing symptoms and monitoring for any neurological decline.
The handling of Ebola virus disease remains highly complex.
Ebola requires highly specialized, designated facilities because of its virulence. And again, it's only spread by direct contact with blood or body fluids, and patients are only contagious after symptoms begin. That long incubation period, 2 to 21 days, requires a long window of surveillance for contacts.
And finally, pertussis, or whooping cough.
Pertussis is highly transmissible via respiratory droplets. Early treatment with antibiotics like azithromycin is key. Nurses have to ensure the patient is on droplet isolation until they've completed 5 full days of therapy.
But the primary nursing role here is prevention through vaccination.
Aggressive promotion of DTaP for children and Tdap for adolescents, adult, and crucially pregnant women to protect the newborn.
That brings us to the complexities of vaccination programs. We know the goal is public health, but what makes the decision-making process so complicated?
It's a risk-benefit analysis for the population. You have to weigh the morbidity, mortality, and financial cost benefit for the community versus the individual. And any adverse events following vaccination must be reported to the Vaccine Adverse Event Reporting System, or VAERS.
And the key contraindications for nurses to remember.
Any history of anaphylaxis to a previous dose is a hard stop. But more generally, nurses must know that certain live vaccines, specifically MMR and varicella, are contraindicated for individuals who are severely immunosuppressed or pregnant.
Our deep dive into community health continues with sexually transmitted infections. This remains a significant challenge because of the social and psychological hurdles involved.
The challenge is immense, really, because of stigma and reluctance to seek care. This leads to silent progression. Many STIs are asymptomatic, which increases the risk of severe long-term complications.
Like pelvic inflammatory disease, ectopic pregnancy, infertility.
Right, and it also significantly prolongs the period where the person can transmit the infection to others unknowingly.
This context is why public health messaging emphasizes safer sex.
Precisely. It acknowledges that while barrier methods like condoms significantly reduce the risk of transmission for HIV and other STIs, they don't eliminate the risk entirely.
Particularly for infections spread via skin-to-skin contact outside the area covered by the condom.
Exactly.
Let's focus on syphilis, which is defined by its 3 distinct clinical stages. We need to understand the trajectory of this disease.
Okay, so primary syphilis appears 2 to 3 weeks after inoculation. The hallmark is the chancre, a small, painless, firm, ulcerated lesion at the site of entry.
And what's crucial for the nurse to know is that this chancre resolves on its own.
It resolves spontaneously within 3 to 12 weeks, even without treatment, leading many patients to believe the problem is solved when it is absolutely not.
If that lesion heals without intervention, the disease spreads systemically, leading to secondary syphilis.
Secondary syphilis occurs 1 week to 6 months after the chancre disappears. This is the stage of generalized infection. You see a widespread symmetric rash, often on the palms and soles, generalized lymphadenopathy, fever, malaise.
And transmission is possible during this phase through contact with these lesions.
It is.
And the devastating final stage, tertiary syphilis, is why early detection is so critical.
After an often long period of latency without any symptoms, up to 40% of untreated cases progress to tertiary syphilis. This is a chronic, destructive inflammatory process that can affect nearly any organ system,
With severe outcomes like aortitis or neurosyphilis.
which can manifest as dementia, stroke, or even blindness.
How is syphilis diagnosed?
It's a two-step serologic process. We use non-troponemal tests like VDRL or RPR for initial screening. If that's positive, we use troponemal tests for confirmation.
And a vital nursing point is that the treponemal tests usually stay positive for life.
Right, but the non-troponemal screening test should decrease in titer after successful therapy. That's how we monitor if the treatment is working.
And the management.
The standard is penicillin G-benzathine, given intramuscularly. If the disease is latent or of unknown duration, 3 separate injections are required at weekly intervals.
Moving to chlamydia and gonorrhea, the most prevalent STIs. The nursing challenge here is the prevalence of asymptomatic cases.
It's staggering. Up to 70% of chlamydial infections are asymptomatic, particularly in women.
Which is why the CDC recommends annual testing for all sexually active women under 25, regardless of symptoms.
Exactly.
And the reason for dual therapy treating for both, even if only one is proven.
Because co-infection is incredibly common. The risk of the patient having both chlamydia and gonorrhea simultaneously is so high that combination therapy is the standard of care.
To properly identify risk, nurses must master obtaining a sensitive sexual history. The CDC recommends the 5 Ps.
The 5 Ps is a non-judgmental, structured tool. They stand for partners,
How many in the past 60 days?
prevention of pregnancy, what methods are used, protection from STIs, what barriers are used, practices oral, vaginal, anal, and past history of STIs. The nurse must ensure privacy during this screening.
What are the overarching management goals once an STI diagnosis is confirmed?
The goals are to increase knowledge about the infection, reduce the anxiety and shame, and dramatically improve adherence.
Which means ensuring treatment is fully completed.
All required doses, yes, and monitoring for serious complications like PID or ectopic pregnancy.
We transition now into the emergency department, the front door of acute care. With 139 million visits logged in 2017, the volume alone is staggering, and so is the staff's exposure risk.
The ED is an environment of constant risk. Abdominal pain, chest pain, cough, and fever are the most common complaints. The staff are constantly exposed to body fluids and infectious agents.
And COVID-19 just intensified this.
It demanded universal screening, mandatory staff face masks, and N95s for direct care, often in conditions of high stress and patient volume.
The ED waiting room itself is often a volatile environment. How does the nurse address potential violence in the ED?
It starts with safety engineering. Security officers, silent alarms, sometimes metal detectors. Nurses have to be trained to recognize and de-escalate high-risk patients.
People with substance use disorders, psychiatric issues, histories of violence.
Right. And if restraints are necessary, they are a last resort and must adhere strictly to Joint Commission standards, requiring specific documentation, monitoring, and maintaining patient dignity.
When trauma strikes, the nurse has to care for the whole family system, which is often in crisis. How do we provide holistic crisis care?
Families go through predictable phases: anxiety, denial, guilt, anger, grief. The nurse's initial intervention is anxiety reduction through honest, clear communication.
And we should encourage family presence during resuscitation.
Yes, but only if a dedicated facilitator is there to explain what's happening and support the family, preventing interference with the life-saving procedures.
If a sudden death occurs, the source material provides clear steps on how to support the family.
Privacy is paramount. The family should be taken to a private area. The nurse must use clear, non-euphemistic language, avoiding phrases like passed on,
Reassure the family that everything possible was done.
and encourage viewing the body, covering any disfigured areas first, and spend time listening. A vital safety alert. Never administer sedation to family members. This can delay or mask the necessary grieving process.
In all emergent care, the approach must be systematic. This brings us to the primary and secondary survey, using the crucial mnemonic ABCDE. Let's break down the life-threatening steps of the primary survey.
The primary survey is rapid and sequential, focusing strictly on immediate life threats. A is for airway.
Is the airway patent?
Right. And in trauma, always protect the cervical spine. B is for breathing. Adequate ventilation. Assess breath sounds, look for chest injuries. C is for circulation.
Which means hemorrhage control first.
Always. Apply direct pressure or a tourniquet to external bleeds. Treat shock and manage hypothermia.
Moving to the less immediate but still critical checks.
D is for disability. A quick neurological check using the AVPU mnemonic is the patient alert, responsive to verbal stimuli, responsive only to painful stimuli, or unresponsive.
That gives a baseline LOC.
Exactly. And E is for exposure. Fully undress the patient to identify all injuries, but then immediately cover them with warm blankets to prevent hypothermia.
And the secondary survey follows once the patient is stabilized.
This is the detailed head-to-toe assessment. It includes a full history, inserting monitoring devices, diagnostics, splinting fractures, dressing wounds. Primary is stabilization. Secondary is discovery.
Airway obstruction is the fastest way to death. What clinical manifestations demand immediate intervention?
The signs are classic and must be recognized instantly. The patient cannot speak, breathe, or cough. They grasp their throat, the universal distress signal. They exhibit stridor, that high-pitched whistling sound.
And remember, cyanosis is a late sign.
A very late sign. You must act before the patient turns blue.
Management for a foreign body obstruction.
If it's partial and they can still cough forcefully, encourage that. If the cough is ineffective or the obstruction is complete, the Heimlich maneuver is the standard intervention.
If that fails, or if there's a severe mechanical injury, the nurse assesses with establishing a definitive airway.
Simple maneuvers like the head tilt chin lift or jaw thrust for trauma patients are the first step.
And there's a critical safety alert about nasopharyngeal airways.
Yes. Never place one if you suspect facial trauma or a basal skull fracture, as the tube could enter the brain cavity.
And the final, most emergent airway procedure, cricothyroidotomy.
This is an emergency procedure used when the upper airway is completely blocked and intubation is impossible. It involves making an incision into the cricothyroid membrane. It's not a long-term airway, but it is a life-saving measure of last resort.
The priority in circulation is always hemorrhage control. Internal bleeding can be devastatingly silent. What are the signs, and how is it managed immediately?
You have to suspect internal hemorrhage if there's no visible external source, but the patient is showing signs of shock.
Rapidly falling blood pressure, tachycardia, cool, moist skin.
Delayed cap refill, intense thirst. Immediate management requires rapid IV access, fluid resuscitation with blood products, and preparation for definitive surgical intervention to stop the bleeding.
The systematic approach continues with the definitive priorities in multiple injuries. The sequence is set to stabilize the most life-threatening issues first.
The systematic sequence is 1. Airway and ventilation. 2. Control hemorrhage. 3. Prevent and treat shock. 4. Assess head and neck injuries.
Then evaluate other injuries.
Chest, abdomen, yes. 6. Splint all fractures. And only then do you proceed with a detailed ongoing secondary survey.
Nurses must aggressively combat hypothermia in trauma because it directly contributes to the deadly trio. What is this
The
trio?
deadly trio is the vicious cycle of hypothermia, acidosis, and coagulopathy, which is impaired clotting.
How does that cycle work?
As the body temperature drops, the chemical reactions needed for blood clotting slow down. Poor perfusion and massive fluid administration then lead to acidosis.
Yeah.
Acidosis further impairs clotting, and the cycle just accelerates.
So to prevent this, nurses must warm the trauma bay, use warm blankets, and critically warm the IV fluids.
Absolutely.
And speaking of IV fluids, you mentioned the preference for lactated ringers over normal saline. Why is normal saline dangerous in high-volume trauma resuscitation?
This is a crucial technical point. Normal saline has a very high chloride content. When you infuse massive amounts of it into a patient who is already hypovolemic and maybe acidotic from trauma, that chloride load can induce or significantly worsen hyperchloremic metabolic acidosis.
And lactated ringers avoids that.
It does. It contains lactate, which is metabolized into bicarbonate in the liver, effectively buffering the acidosis and making it the preferred crystalloid.
Let's discuss abdominal injuries. What are the signs, and how do we manage an evisceration?
Signs include pain, rigidity, guarding, and rebound tenderness. If there is an evisceration where abdominal viscera protrude, the nurse must immediately cover the exposed contents with sterile, moist saline dressings
To prevent them from drying out.
and to prevent infection. Fluids are withheld orally, an orogastric tube is placed to decompress the stomach, and it's a rapid transport to surgery for unstable patients.
For routine soft tissue injury management, how is the wound clean, and what's the difference between primary and delayed closure?
Wounds are cleansed with sterile isotonic saline. A key safety alert: povidone iodine should be avoided deep in the wound because it can injure healthy tissue.
Okay.
Primary closure, like with sutures or staples, is for clean wounds. Delayed primary closure is used for highly contaminated wounds. The wound is left open initially, monitored for several days, and only sutured once the infection risk has passed.
And the requirement for tetanus.
Tetanus prophylaxis is required if the patient's last booster was more than 5 years ago or if their immunization status is unknown.
Finally, forensic evidence collection. This requires extreme meticulousness because the trauma bay is a potential crime scene.
Documentation is key, noting the mechanism of injury and documenting statements verbatim in the patient's own words. When handling clothing, you must not cut through existing tears or bloodstains.
And the crucial, memorable detail here is that every piece of evidence must be placed in a separate paper bag.
Never plastic.
Why paper and not plastic?
Because plastic bags trap moisture, which encourages the growth of mold and bacteria.
Yeah.
This microbial activity degrades and destroys biological evidence like blood and tissue. Paper bags allow for air exchange and preservation,
And a formal chain of custody must be maintained for all evidence.
documenting every transfer to law enforcement. And for trauma deaths, all lines and tubes must remain in place until the medical examiner releases the body, and the patient's hands must be covered with paper bags to preserve any evidence underneath the fingernails.
Our journey through the ED continues with environmental extremes, starting with heat stroke, a true emergency.
Heat stroke is a failure of the body's thermoregulation system. The cardinal signs are profound CNS dysfunction, confusion, seizures, coma, and a core body temperature of 40.6 degrees Celsius or higher.
And the skin is usually hot and dry because of anhidrosis or lack of sweating.
Correct.
How aggressive must the cooling be?
It's extremely aggressive. The goal is to reduce the core temperature to 39 degrees Celsius within 1 hour. Optimal methods include cold water immersion or using cool sheets and ice packs to the major vascular areas, like the groin, neck, and axillae.
But the nurse must monitor the core temp continuously.
Yes, and stop the cooling process at 38 degrees Celsius to prevent rebound or iatrogenic hypothermia.
At the other extreme, we have frostbite.
Frostbite is the freezing of cellular and interstitial fluids, usually in the extremities. The management focus is controlled, rapid rewarming in a circulating bath maintained between 37 and 40 degrees Celsius.
And this must be done without rubbing or massaging the injured tissue.
Right, that causes further damage. Hemorrhagic blisters are left intact, and upon discharge, patients must be warned against alcohol, tobacco, and caffeine due to their strong vasoconstrictive effects.
And the systemic threat, hypothermia.
Hypothermia carries a high mortality risk.
Yeah.
Management prioritizes CAs and requires continuous cardiac monitoring, as the cold myocardium is extremely irritable.
And the major safety alert regarding movement.
If the patient's temperature is very low, below 32 degrees Celsius, moving or touching them can trigger immediate ventricular fibrillation, or VF. so handling must be minimal and extremely gentle.
Next, non-fatal drowning. The clinical picture involves hypoxia, hypercapnia, and acidosis.
The priority is correcting hypoxia and acidosis. This almost always requires definitive airway control, often with intubation and PEEP to improve oxygenation. A nasogastric tube is inserted to decompress the stomach and prevent aspiration of gastric contents.
And the patient has to be monitored closely for days for delayed complications like ARDS.
They do.
Let's pivot to toxicologic emergencies, poisoning, and overdose. What are the three non-negotiable immediate actions?
1. Immediately call poison control for expert guidance. 2. Remove the toxin. 3. Provide an antidote if one is available.
And there are interventions to decrease absorption, like activated charcoal.
Given as a slurry, yes. It binds many substances. Gastric lavage is used selectively, but it carries a high risk of complications.
And the vital safety rule about inducing vomiting.
Never, ever induce vomiting after the ingestion of caustic substances like acids or alkalis or petroleum distillates. Vomiting causes the corrosive substance to damage the esophagus a second time on the way up.
Let's discuss two specific overdoses. First, carbon monoxide poisoning.
CO is a silent killer. It's odorless and binds hemoglobin more effectively than oxygen. Symptoms are nonspecific: headache, dizziness, confusion, and pulse oximetry is unreliable.
Why is that?
The machine reads saturation but can't differentiate between oxygen and CO bound to hemoglobin. Management is immediate: 100% oxygen via a non-rebreather mask to displace the CO, followed by hyperbaric oxygen therapy if indicated.
And the critical management caveat for acetaminophen overdose.
Acetaminophen overdose is a major cause of acute liver failure, often with delayed symptoms. The antidote is N-acetylcysteine, or NAC, given in a prolonged 18-dose regimen.
So what's the key nursing intervention?
Ensuring that if activated charcoal is also used to decrease absorption, its administration must be separated from NAC. Charcoal absorbs the NAC, rendering the antidote ineffective, so the timing must be meticulously coordinated.
The ED is also the primary entry point for victims of violence and abuse, which requires nurses to perform sensitive assessments for intimate partner violence and elder abuse.
These are high-prevalence issues. IPV victims frequently use ED services, and elder abuse is often perpetrated by family members. Nurses are the first line of defense in identifying this.
What should a nurse be looking for during assessment?
Look for incongruent injuries. Injuries that don't match the history or injuries in various stages of healing, which suggests chronic abuse. For elder abuse, look for signs of inattention to basic needs, like severe malnutrition or dehydration.
And the screening must happen in private.
Without the partner or family member present, using non-judgmental, open-ended questions.
And the nurse's mandatory reporting rule.
In many jurisdictions, there are mandatory reporting laws for suspected child and elder abuse. The nurse only needs to have a reasonable suspicion. They don't need absolute proof.
Sexual assault requires immediate crisis intervention and the highly sensitive process of managing rape trauma syndrome.
The victim moves through phases. Initial acute disorganization, which can be shock and disbelief, or a very controlled emotional state, followed by denial and heightened anxiety, like flashbacks, and eventually reorganization.
Management starts immediately with providing emotional support.
And reducing trauma, yes. For legal purposes, the nurse must obtain written, witnessed, informed consent for the examination and release of findings. The patient's history must be recorded precisely in their own words.
Evidence collection is meticulous, closed in separate paper bags. And medical management includes prophylaxis for STIs and anti-pregnancy measures.
Often utilizing postcoital contraception within 72 hours.
A difficult emerging challenge is identifying victims of human trafficking.
These individuals are essentially modern-day slaves, and the ED may be their only point of contact. They often present with chronic, untreated injuries and may defer answers to a controlling companion.
So the nurse has to ask specific, targeted, and private questions.
Yes. Do you control your own money? Are you free to leave? Who is accompanying you today?
Finally, psychiatric emergencies. The core priority remains safety.
The primary priority is always determining the risk for self-injury or injury to others. For the overactive or violent patient, the approach must be calm and firm, using simple one-thought sentences. Security should be nearby.
Restraints are a last resort.
Strictly a last resort, utilized only under one-on-one observation and following strict protocol.
For the depressed or suicidal patient, nurses must maintain a high index of suspicion and use direct questioning.
Have you ever thought about taking your own life? Since males are at greater risk for successful suicide than females, Immediate crisis intervention and assessment of potential for suicide are required before determining disposition.
And recognizing the long-term emotional damage from trauma like PTSD.
PTSD involves intrusive thoughts, avoidance behaviors, and hypervigilance. It's highly prevalent in veterans. Nurses need to recognize that PTSD may present indirectly, such as frequent readmissions to the ED for minor complaints without actual injury.
We move to the final chapter of this unit, disaster management. This framework is necessary when a sudden disruption exceeds the community's capacity to respond, forcing nurses to adapt their skills and often ration resources.
Disaster planning is guided by the National Incident Management System, or NIMS. A core goal for facilities is sustainability planning.
The ability to provide self-sufficient care for 96 hours to 7 days.
Right, before reliable external federal resources can mobilize.
For hospitals, the Joint Commission mandates an Emergency Operations Plan, or EOP, which must be practiced at least twice yearly. This plan is complex. What are the key elements?
The EOP is the roadmap for chaos. It must cover the activation response, who declares the disaster. It needs clear internal and external communication plans, which are notoriously difficult in a crisis.
It also has to detail security, resource identification, and people management.
Right, and crucially, it must include a data management strategy, ensuring backup for the electronic health record, and a plan for mass casualty incidents, including managing mass fatalities and morgue readiness.
This planning is necessary because disaster field triage fundamentally shifts the nursing principle away from routine ED triage. What is the ethical and clinical difference?
Well, routine ED triage dedicates maximal resources to the single sickest patient. Disaster triage flips this principle.
The guiding philosophy is the greatest good for the greatest number.
Exactly. This means resources are strictly rationed based on the likelihood of survival with minimal resource consumption. A patient who is conscious but requires a massive, complex surgical intervention might get a lower priority than a patient who just needs a quick chest tube insertion.
Let's review the standardized mass casualty incident triage categories: red, yellow, green, black.
Okay, priority 1, red tag, immediate. These patients have life-threatening injuries but are survivable if they receive intervention right now.
Like a tension pneumothorax or shock.
Things you can fix fast to save the most lives possible with the least effort.
Priority 2, yellow tag, delayed.
These patients have significant injuries, like stable abdominal wounds or open fractures of long bones, but their condition won't deteriorate rapidly. They can wait several hours for care while the red patients are stabilized.
Priority 3, green tag, minimal.
The walking wounded, minor injuries, cuts, bruises, minor fractures, they can wait hours to days.
And the most ethically difficult category, priority 40, black tag, expectant.
These patients have extensive injuries, like massive head trauma or penetrating wounds across multiple systems, and their chance of survival is extremely low, regardless of the resources expended. In an MCI, resources are not allocated to this group.
They receive comfort measures and emotional support only.
To maximize the chance for red and yellow patients to survive.
This brings us back to the ethical dilemmas in crisis, especially around rationing, like we saw during the ventilator shortages of COVID-19.
This creates immense moral distress for nurses. Normally, patient autonomy guides us. In a crisis with scarcity, however, protocols shift to maximizing societal benefit,
Using randomization to assign ventilators, for example.
which overrides typical patient-centered principles, forcing nurses to watch protocols determine life or death based on fairness, not based on who they think deserves it most. The moral distress was compounded by isolation protocols that prevented family from being present during end-of-life care.
Our final sobering segment is on weapons of mass destruction, or WMD, starting with the most common blast injuries.
WMD incidents often utilize conventional explosives. Beyond the initial explosion, nurses must be alert to secondary devices and the potential for chemical or radiological contamination. And triage has to account for unseen internal injuries from the pressure wave.
The primary pressure wave causes injuries categorized into 4 phases.
Primary phase injuries result directly from the pressure wave and primarily affect air-filled organs. The most common is a ruptured eardrum, and the most lethal is blast lung.
Pulmonary hemorrhage and tearing.
Right. Secondary phase injuries are caused by flying debris and shrapnel. Tertiary phase injuries result from the victim being thrown against a solid object. And quaternary phase includes all other complications, like crush injuries.
Let's focus on blast lung, as it's a major cause of death.
Blast lung requires immediate respiratory support, often with intubation and mechanical ventilation. If a hemothorax or pneumothorax develops, a chest tube is needed, and the nurse has to watch for signs of air emboly.
Next, biologic weapons. These high mortality agents are categorized as Category A and require continuous surveillance.
Anthrax is highly weaponizable. The inhaled form causes severe respiratory distress, shock, and hemorrhagic mediastinitis. The critical nugget here, anthrax is not contagious person to person.
And it's treated or prophylaxed for 60 days using ciprofloxacin or doxycycline?
Correct. Smallpox, on the other hand, is highly contagious via direct contact or droplets. Since global vaccination stopped in 1980, widespread susceptibility exists.
And patients are only contagious after the fever decreases and the rash appears.
Exactly. Management requires immediate airborne and contact precautions in a negative pressure room. Contacts must be vaccinated within 4 days of exposure to prevent the disease.
Moving to chemical weapons. What is the immediate intervention for exposure to agents like vesicants or nerve agents?
Immediate evacuation and decontamination. The patient's clothing must be removed and the skin irrigated as close to the scene as possible. Decontamination requires prolonged lavage with soap and water.
And nerve agents like sarin are extremely toxic. They cause a profound cholinergic crisis.
Pupil constriction, copious secretions, severe respiratory distress. The antidotes, which nurses must be prepared to administer, are atropine and pralidoxin.
Finally, we address nuclear and radiologic exposure. We need to differentiate between exposure and contamination.
This is a vital distinction for staff safety. Exposure happens when radiation passes through the body. The person is not radioactive and does not require decontamination.
Like getting an X-ray.
Exactly. Contamination means radioactive material is on or in the body. This requires immediate intervention.
What are the management priorities for contamination?
Triage must occur outside the hospital to prevent facility contamination. A specialized decontamination area with showers and contained water runoff is essential. Wounds must be covered before full-body decontamination with soap and water is initiated.
And the severity of acute radiation syndrome, or ARS, is determined by the dose absorbed.
Right, and the severity is indicated by the absolute lymphocyte count at 48 hours post-exposure. Triage categories here are often based on predicted outcome: probable, possible, and improbable survivors.
We have completed a rigorous, highly detailed review of 3 massive clinical areas. From mastering infection control to executing the systematic primary survey and trauma to making those heartbreaking triage decisions in a mass casualty incident.
The core takeaway is the mastery of application. It's not enough to just list the steps. You have to fluidly apply EBP, knowing why you use lactated ringers, why the door needs to be closed for airborne but can be opened for droplet, and why that specific sequence in PPE removal prevents tragedy.
That attention to minute detail like paper bags for forensics or stopping cooling at 38 degrees Celsius is the difference between successful and failed crisis nursing.
It is.
And as we close, let's revisit the ethical challenge that underlies all crisis care. Given that disaster forces protocols based on the greatest good for the greatest number, protocols that often override typical patient-centered care, how will you, the nurse, navigate the moral distress of resource scarcity, ensuring patient dignity is preserved even when the protocol dictates a potentially fatal outcome?
That is a professional reckoning required by this unit. Reflect on your personal and professional obligations now, before the crisis hits, because preparedness extends far beyond the technical skills. It requires knowing your ethical line in the sand.
A truly profound thought to end on. Thank you for engaging with us on this critical deep dive. We hope this comprehensive review provides the competence and confidence you need when the stakes are highest.
We look forward to having you next time.